Okay, so today we're going to do an intralesional injection of a keloid scar. And depending on the lesion that you do, there's subtle differences in how the technique works. With a keloid scar, you always want to use a luer-locked syringe. That is to say, something that screws into the syringe. The needle screws into the syringe, whereas a non-luer-locked syringe just gets applied this way. What happens is when I use a non-luer locked syringe in a keloid, this explodes and splashes everywhere, and it's an eye protection nightmare. And I'll show you that in a moment. So first we want to, well, hold on. Let me just make sure. For keloids or other dense lesions, yeah, always use a luer locked syringe. Okay, for keloids of the ear lobule, okay, there's a whole other separate little thing, but basically, here, go to my ear. When you inject an earlobe, some people want...
It can all be edited out.
Well, it's okay, we won't. But what happens is some people will put the needle here and their finger here, thinking that like the needle will only go through halfway of the keloid, but really the needle ends up piercing through both sides of the ear into your finger. So you'd have to, like, you know, hold the ear this way and approach in a way such that your finger is not in the way of the needle ever. Either using forceps or some people put a suture through the ear and pull it out of the way. But anyway, that's not for this discussion. I have to dispose of this. That fell on the floor. That's real life. Okay, so now we're going to start. And here you screw in the luer lock mechanism there and uncap there. Okay, so now we're going to dictate.
First, use an alcohol swab to clean the injection site.
So we have an alcohol swab. And
keep in mind, for most injections, like acne lesions, patches of alopecia areata, lichen simplex chronicus, psoriatic plaques, abscesses or cysts requiring IND, small lesions to be biopsied, or PPD placements, only the bevel of the needle need to be buried in the dermis. That is, intradermal injections suffice.
And when you're doing, I feel like this is Mr. Rogers' neighborhood. When you're doing keloid injections, you have to feel, first you have to clean the area, right? So here I'm just taking a little hydrogen peroxide to clean the area a little better. For a keloid, you have to, not necessarily every place needs to be injected. And what I do is I run my hand across and I feel kind of normal skin and I feel a bump. And wherever I feel a bump or a fibrous part, I feel a certain density. And it's by feel whether you want to do what concentration of steroid you're going to use. In this case, I mean, unfortunately you can't feel through the video, but it's not particularly dense because I have been injecting this for a while. So I'm going to use intralesional 10 milligram per cc. Okay, so we've cleaned the area. Next.
Now you want to stabilize the lesion by placing downward pressure and lateral traction to the lesion with the left index finger.
Okay, so just a note. You can use a smaller gauged needle. Okay, this is a 30 and a half gauge needle. The problem is that it's so thin that when you put it in, not enough fluid can get in the lesion, and the lesion is so dense, the fluid doesn't go in. So I use a larger board, either 26 gauge is ideal, or in this case 25 gauge needle, and that's going to allow the medicine to go in much more easily. So now let's get to it. I have a gauze in my hand to blot at all times, and okay, gonna be a little pinch, and people don't like this at all. Okay, and now I have the bevel of the needle in here, and I'm just pushing, and a little pressure happens, Okay, and you come out. So go ahead. Read.
So make sure you hold the syringe in your right index and third fingers, much like holding a cigarette. The right thumb should be touching the top of the wing base of the syringe. When you insert the needle, make sure it's beyond the left index finger in the opposite direction of this traction. Never inject where the left index finger is in the path of the needle.
So do not inject this way, because you're going to stick yourself. Instead, you always inject beyond. And every time I pull this way, I inject the opposite way. Okay, I'll let you know when the next one's coming. So.
When you insert the needle, put pressure at the base of the syringe to drive the needle forward.
Okay, so I'm gonna do that. I'm gonna do that again. I'm gonna go to the next spot. So the next spot's right here, and again, you see I'm tractioning with my finger. I'm holding at the base of the syringe, and I'm pushing. Because some people like to advance it with their thumb on the plunger, and that just squirts out medicine prematurely. With a bigger bore needle, you get a little bit of extra bleeding. That's okay. Okay, so now I'm gonna pinch.
And once the needle is in the lesion, you can change your thumb from the base of the needle to the plunger.
Okay, make sure you get that on camera. Yes? Okay, sorry. And now I'm going to inject. And what happens when I inject, some stuff can spritz out. And really what I should be having is a glass slide here or goggles to protect me, because it's now quite under a bit of pressure. And you see how it squirted out there, and I was not protected. So I'm going to get a goggle. So just hang on. Or not a goggle, a glass slide. Okay. Go ahead, continue reading.
So once the needle is inserted into the lesion, but before the plunger is depressed, place a glass slide at the base of the needle angled toward the needle, away from you.
Okay, so now I'm, again, injecting. My apologies. Okay, I switched my thumb, and I put the glass slide, and the glass slide obviously has to be this way so it's a windshield. And now I inject. And if I withdraw and inject, you see how it spritzes, and it can spritz at the windshield. Okay.
If you want to hold the slide while putting traction on the skin prior to the initial injection, such that you don't have to reach for the slide once the needle is in the skin, hold the slide with the left thumb index. Use the left fourth finger for traction, then pivot from traction position to glass slide as shield position.
Right, so here, you see I'm holding this in one hand, and okay, again, I'm going to make a stick, pinch, hold on, pinch, now I switch the position, I switch my thumb, and I make the injection again. Very good. Okay, so it didn't squirt out, so we got lucky. Okay, and
when injecting anesthesia into red lesions or cysts, it is beneficial to mark the area to be cut or biopsied prior to injection.
Okay, that we can show in a separate video.
Okay.
But go ahead, continue reading while I finish up.
The volume of fluid can distort the appearance of cysts and lipomas, and the vasoconstrictive effects of epinephrine can blanch red lesions, thereby obscuring the exact place to biopsy. When injecting a cyst for incision, the needle should be inserted tangentially to the cyst, parallel to the skin, raising a bleb at the peak. Any deeper results in fluids being injected into the cyst rather than into the overlying skin.
All right, fantastic, Paul. So partly, you know, we're done here now. At the end of the day, I just want to, you know, feel around and make sure I didn't miss any spots, and I got most of the spots here. And you know, you'd repeat this procedure either weekly or twice a week or once a month, depending on how aggressive the keloid is growing back. And you know, it just depends. It just depends on the clinical exam. Initially, you see them every week, and then as you see that from week to week it's not changing that much, then you're able to extend the visits out. I think we're done.